All right. Good morning, everyone, and happy Monday. I am Laura Line. I'm a principal at Bowling Business Strategies, and I'm really pleased to bring this webinar to you today. It's the fourth in our series of 5. It's birth equity, pregnancy, parenting, and drug use. And we really appreciate you joining us. So this is our 4th webinar. The webinars run through November 2024. We have one more. You can attend any or all webinars, so please join us for the 5th one as well and share it with your colleagues and friends. We have the recordings and slide decks for the previous 3 webinars that we're happy to share out to you. If you want to, if you haven't gotten them already, you can put your email in the chat. We're also going to be posting them on Delaware's Addiction Treatment Resource Center. So that should be up relatively soon as well. And so after this session, of course, we will share the recording and slides with everyone who attended. The first 2 of the webinar series were focused on prenatal care. The 3rd one, which was pretty recent, on September 26th, that was on birth in the context of substance use. And then today's is on postpartum and the infant year 1, centering on the dyad. And so the 5th one in the series is also on postpartum and infant year 1. It's the part 2 of this piece. So please join us. And do spread the word. There is a link here that you'll get when the slides are sent out, or you can use this QR code. Really, the webinars have a wide audience. We really want people to understand birth, prenatal care, birth, and postpartum care in the context of substance use. But our target audiences have been MCO staff and outpatient medical providers, perinatal providers, specialty behavioral health, substance use treatment providers, and other stakeholders. So we really welcome everyone to the webinar. And this webinar is really brought to you by the Delaware Division of Medicaid and Medical Assistance. The views, opinions, and content expressed here don't necessarily reflect the views, opinions, and policies of Bowling Business Strategies, DMMA, or Mercer Government Human Services Consulting. And with that, I'm going to turn it over to our 2 speakers today, Dr. Kima Taylor and Dr. Mishka Turplin, to kick it off.
Thank you, Laura. Excuse me. Sorry, I've been a little sick, but let's see if I can get the slides to move. Story of my life. Oh, there we go. Okay, thanks again for joining us, and we're just going to change. Okay, and just do a brief introduction. My name is Kima Taylor, as Laura mentioned. I'm a pediatrician by training, have worked in the public health area, legislative areas, and others, really focus on trying to increase equitable access to and outcomes from healthcare services, particularly in the intersection of substance use, physical healthcare, mental health care, and particularly around pregnant and parenting people. So I'm very glad to be here. I'm also a co-founder of a new organization called Doing Right by Birth, who I'm co-founding with my partner, who will now introduce himself, Mishka Turplin.
Hi, everybody. I'm Mishka Turplin, OBGYN addiction medicine. And I just noticed that I'm wearing the exact same clothing today that I am in that photograph there. So it's wonderful to be here. And I'll turn it back to you, Kima.
Thank you. And as we go through, feel free to put questions in the chat. Full disclosure, we may not be able to answer them real time because I'm not necessarily great at doing both, but put them in the chat because we will have time towards the end. So just to give a sense of the agenda, I'm going to have context and recap of previous webinars. Then we're going to talk about the 4th trimester, postpartum, talk about the dyad considerations for mom, parent, and baby, then have an overall discussion, which we'll be able to do the Q&A period, and then kind of talk give a brief glimmer of our next webinar. So once more, and those of you who've been on this before, we're going to go through it again because really want to center why we're here. And comprehensive treatment and medication are rare and unavailable for most pregnant people with substance use disorder. So we are here to remedy that. And our overarching goal, I like to have a goal in mind. So as doing the steps to get there, you know where your North Star is. But so what is our goal? Equitable access to and outcomes from culturally and linguistically effective, community-based, non-punitive, person-centered health and social services that seek to preserve and support families, that support improved wellness for parent, infant, and dyad. I have a tendency to talk quickly, so I'm purposely trying to slow down. So if we go too fast, definitely put something in the chat. So I want to level set us because I think when people talk about equity and equitable outcomes, they mean different things. And that's fine, but I do want to be able to center us for this conversation so you understand what we mean when we're talking about this. So for myself, equity is not the same as diversity, equity, inclusion internally, though that is incredibly important. And equity and access does not necessarily lead to equitable outcomes. You can have lots of people going into the healthcare system, and as we know, they kind of get churned up and we still have outcomes that tend to be inequitable and often poor. Equity and equity lens must be in all areas. And we're thinking of doing this work, you have to think about whether there's equity in all areas, policy areas, practice areas, program development areas, implementation, evaluation. Doesn't mean you can do all at once or have to do all at once, but please do start in one area and then spread the equity lens throughout. It requires changing the way we're taught and often changing the way we think. And I'm going to have a slide that alludes to that. But equity is not a pull out, an add on, or a tag along. You don't do all the work and be like, okay, now we're going to throw some equity in there. It really has to be centered from the beginning. We have to recognize that many of our policies, practice, and programs that are currently in place are embedded with inequities. They're structural inequities, so we have to think about dismantling them as we move forward, which means you really have to start at the beginning. And the key, particularly for me, is equitable outcomes from our policies, programs, and practices. This requires data and accountability. And data isn't just like little numbers and check boxes you mark and then you get an Excel spreadsheet. Data is also talking to people, understanding their realities, having the ability to listen to what's working, what's not working, and trying to make the changes necessary. Accountability isn't just in cutting off providers or cutting off services. It's recognizing, okay, maybe this isn't working, and let's do a performance improvement plan to see if we can get to a space of equitable outcomes. Now, if people continually do harmful things, yes, they may need to be cut off. But a lot of this is really working in partnership with providers, patients, families, as they define them, and systems to really get the equitable outcomes that we hope to see. It is hard, but it is achievable, and that's what we need to work towards. And so to start most of my talks, I start with this because it really gets this idea that we have to start thinking differently and be brave enough to start thinking differently. I mean progress, and this is from a book called Transcendent Kingdom, Gyasi, which I highly recommend. It actually touches on the topic of substance use. But it says, I mean progress in the sense of the natural way in which learning something new requires getting rid of something old. Like how discovering that the world is round means you can no longer hang on to the idea that you might one day fall off the edge of the earth. And now that you've learned that something you thought was true was never true at all, every idea that you hold firm comes into question. So this is really, I mean, progress in the sense of letting go that punishing and harming people is going to get us where we need to be, which is equitable outcomes that really seek to preserve families. It means discovering that the world is round and we have to think differently. And we want to, as part of this conversation, try to push you guys to think differently. I know that no one webinar is going to change everything, but it might change us and make us a little more inquisitive to start doing the changes that are needed to achieve those equitable well-being outcomes and achieve our goal. So now I'm going to pass it back to Mishka. And I'm going to let go.
Great. Thank you so much, Kima. And I just want to begin by reviewing, like in a little bit more detail than we have before the prior webinars. They're organized narratively, really, in an arc: prenatal care, birth, and postpartum. And we're really at the transition to postpartum right now. And in the first one, we talked about like preconception care, really somewhere the most important prenatal care visit is the preconception one in particular from a chronic disease management. That's the one people are least likely to obtain. And for people who get health insurance because of pregnancy, one that is actually unattainable. We talked about the difference between what's a drug test and what is a screen for substance use and diagnosis of use disorder. We focus primarily on the treatment of opioid use disorder with medication, both initiation and continuation in pregnancy, touched on other chronic conditions, and tried to put this in the context of harm reduction and the importance of care coordination. For the second prenatal care one, we expanded the lens beyond opioids to include other non-opioid substances and what the sort of management of those conditions is. We also began to introduce talking about child welfare in that second piece, with emphasis really on the plans of safe care. And we had somebody, Jill came in to talk about that in much more detail. And then we talked about the importance of planning for the birthing hospitalization. The last session was really focused on labor and delivery and thinking about birth in the context of substance use and use disorder. And I wanted to identify, like, just sort of to stand up the principles of care that were developed, that we developed in the prenatal remain true, during the birthing hospitalization. We paid particular attention to analgesic considerations and options to make sure that people, can be, cared for appropriately during birth. We talked about the comprehensive management and assessment of newborns. And we had Lauren Pock, who was a lawyer, talk about, sort of the context of mandated reporting with emphasis on Delaware, but shared resources that are available and relevant, to other states. So, oh, that worked. So I wanted to really then begin as we talk about postpartum by let's define the term dyad. We've used it a lot, but we actually haven't defined it. And there's lots of different ways one might define it. And my favorite definition is this one from Dr. Winnicott. He was a pediatrician who then went back and trained as a psychiatrist. And he's the person who described the blankie, the attachment a child has to an object. And he also described a baby. It, in a sense, really defined the dyad. And he wrote, "There's no such thing as a baby. If you set out to describe a baby, you will find you are describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship." So as we go forward, as we're in the, postpartum period, I want us to hold this definition close, to really think about how do we support the dyad? How do we support the things that are actually, in his definition, truly indivisible? So you've probably heard the term the fourth trimester. It's been used in slightly different definitions, but how I'm using it is really to be the same as postpartum, which is defined as the year following the end of the pregnancy. We tend to think about this primarily around live births or term births, but it's also a concept that applies to miscarriage and abortions. I like the term the fourth trimester because it's inclusive of the previous 3 trimesters. And this is a real important period. It's a critical period. This is, for early attachment, which is, Kima's going to talk more about in this session and the next one, which is really essential for early childhood development. This is the time of, breastfeeding and chest feeding. This is also a time of mood changes, sleep disturbances, in particular for the birthing parent, and physiologic changes that are normal sort of post-pregnancy. This is also a time where the sort of ideal, the cultural norm of the ideal mother collides with really what it's like to care for a newborn. This is a period of insurance and welfare realignment, even in states that have expanded Medicaid postpartum. eligibility for services may not be the same as it was during pregnancy. And clearly, the arithmetic of like the family unit has changed, and that might shift eligibility as well. But it's also a neglected period. Think about how we structure prenatal care, right? It's monthly and then increasing frequency of visits until the birthing hospitalization. And then historically, it was 1 or 2 visits in the postpartum period. Care really shifts from being focused on the birthing person to more focused on the newborn, and generally speaking shifts away from healthcare settings to non-healthcare settings. In many ways, like one of the few like potential like providers whose might be continuous from prenatal care to postpartum is the addiction medicine doctor. Now, sometimes a family doctor can be, sometimes there are others workforce that can be, but on the whole, my field, obstetrics and gynecology, really has neglected the postpartum period. And I think, as I'll show you, this is to some extent to the detriment of the people that we serve. So most of you are aware of this. This is really this is a figure that looks at the death rate during birth from the 1880s until like the mid to latter part of the 20th century. And this is one of the huge success stories of modern medicine in the 20th century, was a marked decline in the likelihood of dying during childbirth. It was about 5 in 100 around the turn of the 20th century. And by the time I was in medical school in the 90s, it was about 1 in 10,000. And this had to do with the advent of antibiotics, of blood transfusions, and of modern anesthesia. But I think, as most of you are aware, ever since I've been in medical school, rates of maternal death in the United States have only been increasing. And this is in contradistinction to much of the so-called developed world, as illustrated here. And in many ways, the United States is a marked outlier in terms of maternal deaths globally. And it's maternal deaths. There's a lot to talk about in here. And I just want to focus on the intersection between substance use and use disorder and maternal deaths. We're going to talk more about deaths in the postpartum period, but I want you to know that people with opioid use and use disorder have between 3.5 and 4.5 times the odds of death during the birthing hospitalization, as seen in these 2 articles here. And it's unclear exactly why that is, but I would posit that some of it has to do with discrimination, and that we don't listen to people with use disorder as closely as we listen to other people complaining of legitimate concerns during birth. But the real attention has been to the role of the opioid crisis and overdose in particular to maternal deaths more generally, most of which are happening in the postpartum period. This is some of the most recent data that looks at this. And you can see sort of like on the right-hand side, like overdose deaths being like increasing and contributing to the overall cause of maternal deaths in the United States. This is another way of looking at the same data, and it's sort of stratifying like all deaths, and then by the I don't know, peach color is with amongst people with opioid use disorder. And you can see clearly overdose being the most common cause of death, and clearly more common amongst people with OUD. But also, injuries, suicide, deaths during pregnancy and delivery that I had just mentioned from the other stuff, even circulatory diseases and homicide. So the weight of postpartum mortality really like rests to a large extent amongst the population of people with opioid use disorder. But deaths are really, in many ways, the tip of the iceberg. There's different data that people have come up with, and this might have been adjusted since I last looked at it. But for every like overdose fatality, there are at least 10 non-fatal overdose events. So that's why we think of the deaths as really kind of like the tip of the iceberg. And these are data from the state of Massachusetts looking at all overdose events, both fatal and non-fatal, across time, pre-pregnancy, during pregnancy, and then through the postpartum period. And you can see here on the top, the one that's labeled A, that overdose events decrease through the course of pregnancy, only to increase postpartum. And in fact, at the end of the towards the end of the postpartum period, overdose events rates are actually higher than they were in the year prior to delivery. And I'll say that there's a little bit of data looking at overdose events in the second year postpartum, which I haven't shared with you, and the overdose rate remains elevated. On the bottom, this is like sort of stratifying the overdose events by people who are receiving medication versus people who weren't. And you can see what we know and what we've known for a very long time, that medication is protective against overdose events. But it's not just medication, it's also naloxone. And I think everybody on this call knows what naloxone is. It's an opioid antagonist. It reverses an overdose. It works because it has very high affinity for the opioid receptor, which means whatever is bound there that's causing the overdose, it displaces and it reverses. So it is truly life-saving. It's not scheduled, it's not addictive, there's no potential for abuse. It only works if somebody has opioids in their system. If somebody doesn't, it has no effect. Hence, it's safe. It's safe for pets, for children, for people who are pregnant, really anybody. But it's temporary. It wears off, 20 to 90 minutes. And that means that some people who have, especially like fentanyl or a lot of opioid on board or something with really also high affinity, that you can reverse the overdose, they slip back in. They can reverse, you slip back in, which is why really there's no limit to the amount used. But we do a bad job getting naloxone into the hands of people when they're leaving the birthing hospitalization. And there's lots of community-based resources to push it out, but something to think about in the future is how to better get naloxone into the hands of people when they're being discharged from the birthing hospitalization. So from this, I want to shift gears a little bit and talk really about two important things to think about in the postpartum period. The first is hepatitis C, and the second is contraception. And hepatitis C, I think, as everybody knows, rates have been increasing in parallel with the opioid crisis. People talk about the syndemic of opioids and opioid use disorder and hepatitis C, in particular due to both injection and intranasal drug use. And these are somewhat older data, but they're pretty compelling. This is the state of Ohio and looking at maternal hepatitis C virus infection rates by county comparing 2006 to 2015. And you can see a marked increase in the number of counties, which had, towards like 3% rates of maternal, that would be the blue. And then a couple of counties where it's 5 to 7%, which is the purple. And on the right-hand side, this is the racial ethnic breakdown of people with hepatitis C overall increasing, but in particular, increasing for white non-Hispanic women, mapping onto who are the people who are more likely to be using opioids. And in many ways, this is actually a pretty good time to have Hep C, because we have, treatment available, and that is shorter course than historically, and a higher, cure rate. Um, the but um, but uh, um, there's a huge sort of knowledge gap, both amongst providers and amongst patients. This is a study that looked at sort of knowledge about Hep C amongst pregnant people with opioid use disorder. And what they found was that this is that 92% of the people surveyed had a risk factor for hepatitis C. Um, but knowledge on the whole was like poor to middling. People did not think you could get to hepatitis C through intranasal drug use. Um, they they also failed to identify the importance of pediatric follow-up, and I'll touch a little bit more on that shortly. Um, And this is another study that really looks at the cascade of care from pregnancy to postpartum for people who are pregnant with opioid use disorder. And there were about almost 800 people who were pregnant with opioid use disorder, of whom, only 77% were screened for Hep C, um, you know, of whom actually 60% were positive. And then people who were screened, many of them, it was a new diagnosis. But only 25% with a new diagnosis got subsequent testing for viral load. Um, and only 10% received immunization for hepatitis A. And although like almost all of them, about 75% were referred to hepatology, only a quarter of them attended the hepatology consult. And only 1% of these people were actually receiving treatment for hepatitis C 1 year after delivery. So this is a massive failure. We have a medication, a treatment, several that work, that we don't yet treat people in pregnancy. I can talk more about that in the Q&A, but postpartum for people who were doing a bad job screening, then doing the proper screening, then linking people to the initiation of treatment for a curable condition. Now, kids who are born to people with Hep C need to be followed to make sure that they don't seroconvert. And I didn't put that slide in here, but there's data from the state of Tennessee, which is a similar study to this, a cascade of care in the like newborn and early childhood, where it was some like 300 infants, of whom, at best 15% were actually tested, at 2 years of age. So there's lots of opportunities to think of, a chronic life course, and very impactful public health interventions to address hepatitis C in the postpartum period. So I want to transition now to talk about contraception. And I want to frame it a little bit from this sort of classic life course figure from the Guttmacher Institute, in which they state that the typical woman spends 5 years pregnant, postpartum, or trying to get pregnant, which means they spend 30 years trying to avoid pregnancy. And I'll say from a public health perspective, we put most of our programming into that pregnant period, a lot less into the postpartum period. And we don't really take this sort of reproductive health life course like into account as much, in particular around pregnancy and postpartum. Now, there's some really wonderful public health projects that have massively expanded access, in particular to long-acting reversible contraception. And by long-acting reversible contraception, I mean like IUD or the implant. These are the most effective forms of birth control, more effective than either male or female sterilization. And this was a project that started in 2009 in the state of Colorado and tracked data through 2014. And the report was released in 2017. And this was funded by an anonymous donor in which they used the Title 10 clinic system to provide free birth control, all options, including long-acting reversible methods, to anyone who wanted them. This program sunsetted when the state legislature did not approve continued to pay for it themselves. But what you saw here, and this is like well illustrated here, is the market increase in the sort of uptake of long-acting reversible contraception. They saw a market decrease in unintended pregnancies in general and in adolescent pregnancies in particular. So this is here to show that states can and have effectively taken the unintended, out of many pregnancies. Now, in the context for opioid use disorder, this is a similar study to sort of the hepatitis C cascade, but focused really on contraception. And they took a group of people like with opioid use disorder who were pregnant and asked them, as part of prenatal care, is asking people what kind of postpartum contraception you want. And about a third of the people said that they wanted a long-acting reversible contraceptive method. However, and this is the red stuff here, during the birthing hospitalization, like less than half had any sort of documentation of what their desired method was. Many people got a short-acting method. And then they were referred, for the postpartum visit to get, for contraception, of whom like less than half attended. So in the end, only 40% of people who wanted a long-acting reversible contraceptive method in pregnancy actually got one. And 0% of people who said they didn't want one got one, which is also good. So this illustrates multiple nodes of sort of missed opportunities to talk about contraception during the birthing hospital, to even provide contraception upon, in the hospitalization or upon discharge, as well as like illustrates how if we put everything in that postpartum visit, some of the time it doesn't happen. So with that, I am going to transition it back to Kima. Sorry about jumping ahead. And thank you.
Hello.
I think you're 3 slides ahead. Sorry.
That's okay. There we go. Okay. So thanks. So we're on now to the newborn infant. And last time we did talk about newborn assessment. So this isn't really to dwell on that right now, but to once more remind us that assessment is really important. Helps determine how we can care for the infant and dyad, whether they will ultimately need pharmacotherapy, so when they can go home. And when they do go home, what instructions we should be giving. And so it is important to assess for the full picture. And even as Mishka was talking, it really gets when I think of harm reduction, I do a lot of work on harm reduction. I have a very broad definition. And it speaks to not just focusing on the substance use. One, it is not just naloxone, but it's also not just focusing on the substance use, but it's that whole breadth of services that unfortunately, because of stigma and previous thoughts about people who use drugs, they often don't receive. And so this assessment is important so you can give full and accurate guidance and anticipatory guidance about the whole parent-infant dyad. It is important, excuse me, it is important during this time to also continue and think about those non-pharmacological interventions. And it's particularly a time, like Mishka alluded to the fact that when you go home, you're exhausted and parenting is hard. Two, you've been told, okay, now this, your substance use, we're going to focus deeply on that. And it makes you hyper vigilant and somewhat scared. And I think it does, parenting does for all of us. So really continuing and remembering these non-pharmacological interventions of gentle handling, swaddling, being with the infant, skin to skin contact, and really that education is going to continue to be important. So now we've kept saying we were going to talk about breastfeeding, and now I want to talk about breastfeeding because most of us have really heard, slowing down, the positive effects of breastfeeding on an infant and the parent. This includes for the infant lower risk of asthma, obesity, type 1 diabetes, sudden infant death syndrome, fewer ear infections, fewer stomach infections. The idea that the antibodies in the breast milk help develop the strong immune system. We also know there's positive benefits for the parent that can include decreased risk of breast or ovarian cancer, decreased risk of type 2 diabetes, and high blood pressure. And the American Academy of Pediatrics, I'm trying not to use it's the abbreviations, but the American Academy of Pediatrics and others really recommend exclusive breastfeeding for 6 months, continued breastfeeding as you introduce other foods into the diet. So, recognizing these benefits of breastfeeding, we can offer the same benefits to pregnant and parenting people who use drugs who are on MOUD, like buprenorphine or methadone. For a long time, there was just feeling that you couldn't offer breastfeeding, that parents who use MOUD should not breastfeed. But like others, can really have those positive effects and more. It can have additional benefits like decreasing the incidence, severity, and length of stay for neonatal opioid withdrawal syndrome. It can decrease the need for medications, shorten hospital stay. And only a small amount of that MOUD is going to reach the infants. There's a very small amount in breast milk, and it's less than you would give for pharmacotherapy for nows. And this breastfeeding can also strengthen those bonds. Some hospitals have in place eligibility criteria and make sure these are evidence informed, but you should ask your hospital. And some of that's like making sure the parent is in treatment with SUD counselor or in recovery times 90 days. I am not telling you what your eligibility should be. You should look into it, but you should also make sure, like we talked about before, that there aren't any inequities baked into it and that it really is evidence informed. So, MOUD is not a contraindication to breastfeeding. There may be other contraindications, and that's going to be important to note. I listed some here. And it's not just related to substance use, there might be other medication indications. So, again, there's a link there. But it is important to offer it. And if the parent is having difficulty breastfeeding, because many do, that is reality, making sure that we don't say, oh, forget it then. Offer a cultural linguistically effective lactation consultant if difficulty arises. And that should be in the hospital. But if difficulty continued, if it's there's continued difficulty upon release, in continuing that lactation consultant, which is also nice because it's another touch point for the parent. I do want to say, though, that there are some parents who are unable to or not interested in breastfeeding. And sometimes our society goes kind of all the way to the other side, and then we start criticizing and ostracizing those parents. That is not helpful or useful. So, really working and partnering with parents to understand what the benefits are, coming to a partner decision of what they want to do, and then supporting them whatever they decide. Excuse me. So now I want to talk a little bit about the discharge period. And I put this AAP policy that's the minimum criteria and states it's unlikely to meet this criteria in less than 48 hours. And I really think this alludes, I don't know how old you all are, but it alludes to that time where HMOs and others tried to say that anyone at a vaginal birth can go home in 24 hours and a C-section was 48 hours. And then the backlash, which demonstrates the importance and power of patient voice, the backlash got rid of that, thank goodness. And so parents were able to stay longer than that. But really, to do what you need to do, often infants need to stay about 48 hours. And if not, again, partner discussion with the parents and understanding of anticipatory guidance as they leave. During this period, you are doing the assessment for neonatal opioid withdrawal syndrome, but also the regular newborn stuff, for lack of a better way of saying it. That includes blood tests, hearing tests, heart screens, making sure that there are no other concerns that are going on with the newborn. And it's interesting because we do eat, sleep, console, right? Well, a lot of times infants who have pneumonia, I'm sorry, sick this weekend, pneumonia, or who have sepsis, like they're going to have some of the same signs. They're not eating, they're inconsolable, etc. So not solely focusing on substance use, but really looking at the entire infant and providing all the services you would for a newborn. That includes making that pediatric provider visit within 2 days of discharge, making sure they have a car seat and that it's put in correctly, and then making sure before they leave that they have a safe sleep environment at home. So the baby's alone on their back in a crib and don't smoke. And that safe sleep environment, I don't know, but in Baltimore and other places, it's important because often they can be offered a pack and play. But if not, the AAP also has other possibilities that can be utilized in the excuse me, in the short term if they don't have that crib or bassinet or pack and play at home. So now I want to focus a little more on opioid exposure. And the AAP does have a discharge checklist for infants with opioid exposure. And you'll notice we like to give a lot of links because this is a lot of information we're throwing at you at once. And so I want you to be able to go back and find it again. So this talks about an AAP discharge checklist. Again, I want you to think about this in the broader context of everything, but it does allude to having a follow-up appointment within 48 hours of discharge. Obviously, before you discharge, you want to make sure there's not significant clinical signs of withdrawal. But even if they're not, you really want to have a connection point for that parent and pediatrician within 48 hours. You want to have a discharge plan that may include home visiting, as is mentioned here, but really knowing and making sure you're connecting them to culturally and linguistically effective home visitors who provide non-punitive support and really understand NOWs and substance use disorder. People are like, oh, just give a home visiting referral. Often the home visitors do need to have the substance use education, a substance use understanding of NOWs and making sure that exists. So you're increasing the supportive environment and non-punitive environment for that parent. And again, making sure it's culturally and linguistically effective. And when I use those words, a lot of people, I never use culturally competent because it's really hard to know everything and be competent in everything. And so it really requires cultural humility, having the capacity to listen, and then how to create a partnered effective relationship, recognizing someone's culture and ensuring there's linguistically effective care and making sure at the end of the day that you're working in partnership to improve outcomes as defined by you and the patient. So it's really having those culturally and linguistically effective home visiting services. Providing parent support. You know what? Parents are exhausted. Having an infant and taking them home is really tiring. And they just gave you all this guidance and information, and your brain's churning. And then often your child may have, though they aren't significant, still clinical signs of withdrawal, which may mean they're a little fussier. They may be somewhat irritable, crying a bit, may have some vomiting, diarrhea off and on. And so that's stressful. And so it's offering the parent support, which we're going to talk about later. But also in my case, I think it's offering having them understand they can call their provider. We give a list for people of these are the times when you should be scared for your infant. And that's important. Like if a baby has a fever over 103, please come in. But there also needs to be ability to call to be like, I just don't know. I'm kind of scared. Can you help me? And so providing those parental supports and recognizing that if the infant was on pharmacotherapy, sometimes they're weaned off in the hospital, other times they're weaned at home. And so making sure that the parent understands what that's going to look like, but also that you're linking them up to a provider that understands what that looks like. So I want to touch a little bit on care coordination, and it links up to the whole piece about parent support. And it really requires that there be evidence. I want to be really honest. This requires that there's evidence-informed, cultural linguistically effective, community-based services that really support and understand substance use disorder in the community. We do not have enough of those. So this is one of those things that we're doing while we're, building the plane while we're flying. We need to build more of those culturally linguistically effective community-based non-punitive services. We need to do it in a cross-sectoral manner, including pregnant and parenting people who have used drugs, continue to use drugs, perhaps, adult children who have been in that experience. So I know that there are not enough and we still need to build that. But in the meantime, there are some. And so this really requires hospital staff and providers to become acquainted with what these are. What are those non-judgmental, non-punitive, home visiting, pediatric, WIC, other services? And once you have kind of an idea of what exists out there, you then got to ask the patients and the parents what supports would be helpful. And so I say ask supports would be helpful and then which ones they need. Because often folks may be like, it'd be really helpful to have a babysitter for 8 hours a night. That can be my mom. She has volunteered, right? So some of the supports they may have in place, but ask them all of them, then define which ones they need. And that's going to change. Maybe then the parent, their mom goes home and, they no longer have that support and you need to think about respite care. So having a breadth of their needs. And there's some great screening tools. I use SDOH as societal determinants of health because really these are something society has determined whether people will or won't have, but screen for them. And there's some great tools out there. They need to be cultural linguistically effective. They need to be translated in mirrored language, go along with health literacy guidelines and more. Second, once you identify these places, develop relationships with those providers, community-based organizations, and others that provide these culturally linguistically effective supports. Sometimes those supports, like I mentioned before, could be a free pack and play, could be amazing lactation consultants, childcare. This is really huge. It's helpful for folks to have childcare, diapers, formula, whatever that is. Create those relationships because often those referral and feedback loops helps everyone. It helps you know that you're sending your client to someone that you know and that you can continue the follow up with. Vice versa, often for those say the childcare, they may have another mother coming in that then is finds out she's pregnant and they know who they can send their clients to. So that back and forth is going to be really important. Work with family support systems. Bring family as they define them in to hear that anticipatory guidance. Allow family to ask questions. This happens a lot in pediatrics around safe sleep, let alone back in your crib and not smoking. Because, a lot of say grandparents be like, no, you got to let the baby sleep on their tummy. And so you bring the family in, you say, well, these are the reasons we actually are saying they should sleep on their back because X amount of time of research has demonstrated that this is safer for them in terms of sudden infant death. Once the campaign started, you can see the drop in the deaths from this. So really having them, but also and the parent's exhausted. And oftentimes, again, you're getting all this information at once, and it helps to have other people hearing it and storing it for when the parent has other questions. And then last but not least, partnered care coordination across physical, behavioral, and social supports. And that means, yes, ensure, again, harm reduction means really looking at all aspects of the client, the parent and the baby, making sure they have access to culturally linguistically effective, non-punitive physical health services, mental health services, substance use services, and social supports. But it means a little more than that. It's like take into account real life. I was lucky enough to work in FQHC, which had maternity care and pediatric care and social worker all in one space. So you can make an appointment for the same day back to back. So they weren't going back and forth. And that wasn't required, particularly when there were transportation concerns. So thinking of their real life and what can possibly make it a little easier for them. And again, really making sure you're thinking about coordinating with community-based, non-judgmental partners who are going to offer that cultural linguistically effective care. And it's important to stress, though I haven't before, there is no one size fits all. And understand and knowing that is important, but that's why it's also once you find those partners, literally keeping a list, literally kind of keeping I was going to say notebook, which ages me, but keeping a list on your computer that you can share with others. And that requires talking to the patients. Because often what happens is you're like, oh gosh, I have this best friend that runs this clinic. And the patient's like, oh no, I don't want to go there. And they don't necessarily tell you why. You're like, no, you have to go there. Create that partnered relationship so they can say, look, they don't treat me well. I feel really judged there. And two things happen with that. One, you work with them to send them someplace else. But two, you can tell your friend, like, folks feel judged. Like, why don't you think about some of the interventions you can make to really help this be a welcoming place for people so they get the care that they need? So the last piece I want to talk about, and it's kind of linked with care coordination and all that physical, technical stuff. In all of this, a relationship is budding. And so it's really important to support parent and infant bonding to really help support that relationship development. Bonding is well-being both for the parent and the infant. It makes you feel better. There's love shared, there's kindness that's really needed in that space. And so support that early bonding as much as possible. Help parents to embrace those special moments. And that means like really taking the time and saying, hold your baby as close as you can and look in the eyes, make eye contact and feel what each other are thinking. Feed close, console, just spend time holding. Helping parents ask for help, particularly when you've been historically marginalized. And again, when you've been historically stigmatized, you're loath to ask for help because people use it as a bludgeon against you. Well, she couldn't. Well, they couldn't. Help your folks ask for help. Everyone needs help. And by that, saying, like, it is okay to leave the kitchen dirty while you cuddle with your baby. If you have the means to have someone come in and clean. So that's a lot of people up in the house, but like absolutely cuddle your brother. Let others bond. Like it is okay to ask for help and take a nap and let someone else bond with your child and show them how to bond. And some of those, when they eat, blah, blah, blah. Play, sing, read to your baby. Embrace it, enjoy all of it. Even when people are like, but that baby is only 2 days old. They don't understand what you're reading. Do it anyway. Also, I think this is really important. And the one thing I always stressed when I was seeing patients is no parent will be perfect. Allow for some grace and kindness. I was not a perfect parent. I assure you, you can ask my children, I still am not. And so allow for that grace and kindness to be like, I made a mistake. Can you help me figure out how to do it better? Grace and kindness. So people will actually tell you, like, oh my gosh, I co-slept. I know I'm not supposed to co-sleep. Well, help me, right? And so knowing that and being honest with yourself, because often in this society, we're so uncomfortable with the fact that we're not perfect parents will take out other parents. No, let's have this be a graceful space. And then really thinking about assessing for depression and exhaustion. Again, this is a hard time. Often we've spent a lot of times ignoring substance use disorder, but we've also spent a lot of time ignoring depression. And even as we look at those overdose deaths, some of them are accidental overdose, some of them have to be suicide, right? If you looked at the overdose, there was also high suicidality. Like, where do those two overlap and what are we doing about it? Assess them. And I'm saying this from a pediatric point of view. In many states, you can actually do a pediatric screen and charge the infant's Medicaid, but even if not, do it because parent as treatment for the infant means you're going to have a healthier infant as well. And there's remedies that as we're building this plane of the services we want to see in community, there are ways to think about it. Australia, they have a lot of respite care. Could we offer respite care while we're building this plane? So really understanding the holistic parents lets you advocate and create the systems that will really achieve the outcomes we hope to see. Lastly, and we'll discuss this a little more in the next webinar, but do want to talk about the infant's first few days and that first pediatric provider visit. I do realize the first few days are not all encompassed by the pediatric provider visit, but do want to talk a little bit about that visit and helping the parent because some of that's anticipatory guidance when they leave the hospital. You are going to leave in 48 hours. You're going to have this appointment with the pediatrician. When you get there, the pediatrician's going to, so they understand. They're going to ask you a history and physical. Yeah, they have your chart, but they're going to ask you the medical history of yourself and of the infant. And of the infant, they're going to ask about whether the parent had, whether they were exposed to substances, whether they had NOWs, whether they just had non-pharmacological interventions or prescribed medicine. They're going to ask about those things. So have your chart ready, have your discharge papers ready. They're going to ask whether it was vaginal or C-section. They're going to ask about your history, parent, about HIV, Hep C, Group B strep. They are going to ask whether the newborn screens were done. There's heart, genital heart, is the hearing and blood, whether they had vaccines, whether they had vitamin K, like all those things folks are going to ask, and they ask every infant. So this is for them to build knowledge and build relationship with you and your infant and the dyad. And it's understanding the pediatrician is then going to go into some of the questions about, are they eating? How often are they eating? Are they peeing? Are they pooping? How often are they sleeping? This behavior that remarkably aligns to eat, sleep, control, and console, because we talked about how that's kind of like the natural pattern of caring for the infant. And we'll give them indications on whether, though not significant, whether some of those withdrawal symptoms still exist. But again, those are kind of harbingers of other things. So we'll get a sense of, why is the baby fussy? Are they breathing well? Yada, yada, yada. They're going to ask social and family history and that kind of questions, which gets to the societal determinants of health, what's missing, what's needed. They're going to do a review of symptoms. They're going to do the physical and make sure that, they do a full physical, which means they're going to manipulate the baby and all of that. And then they're really going to do some anticipatory guidance. And often they will give you a sheet to take home with you because it's a lot. And often, like, you still have that car seat. Are you still using your safe sleep behavior? Are there barriers to either of those? How often are you feeding? And a lot of this anticipatory guidance. And as I said, a lot of at the end will be when to call the provider. And it's often the catastrophic things that you want to call the provider. But most providers are like, if you have a question, if you're concerned, call. Right? It's better to call than not call at all. And so really making people feel comfortable. You're not bothering people. You're not like, call. And then really discussing the plan. And we talked a little bit about the plan of safe care that could be discussed. But as I mentioned in that conversation, all babies have a plan of safe care for moving forward. And they'll talk about some of that. Again, many people will provide a handout, but some of the developmental and other things you should look forward to. And then when your next follow-up is. We are going to go further than this in the next session, but as Mishka mentioned, and as many of you know, you see a lot of the pediatrician in that first year. And so having that understanding of what comes next is often helpful. And it really is helpful to build that relationship. I will say the nice thing about pediatrics is you're not just caring for the patient, the infant, you do get to have a relationship with the parent and the family as they see them. And so it's a really positive time to build bonding, to have honest and respectful conversations if you build that safe, culturally linguistically effective, non-judgmental zone. So I am going to end, we made it under an hour, and really open it up for Q&A. And I think I mentioned at the beginning, you should put your Q&A in the chat, but I actually now see there's a Q&A box, so I will check those as well. Any questions? If there are no questions, I just want to remind people that, as Laura said, we will hand out the slides and the webinar, but there are links in the, as I mentioned, the slides that you can see, and there's a resource page at the very end, and you can click those links.
We welcome questions. Typing them in. However, there was one question, from last time that we didn't get to. I'll read it and maybe we can discuss it. It was, how do you provide supportive services for those individuals who are parenting in recovery and are using other substances?
I can start and then you go. Is that okay?
Yeah.
Okay, cool. I think it's much of what we talked about before. It's really asking what you need, assessing what they have in place. I can't speak to all of the states represented, but knowing ahead of time what services are available. That is often the home visiting. And I'm mentioning these because states get money for things like this, but home visiting, WIC, SNAP, all of these different pieces that can be utilized to support the parent. But I also, there's some other programs that I think of in terms of like group parenting. Often you can create structures where the parents are supporting one another. often you can create structures like there's another program that Michigan and I talked to recently, Healthy Steps, where they really bring in a developmental person to help the parents. Any way that the parent, whatever supportive services that the parent requests. And so this gets me to really what I want to say is you have to talk to people. I think, we see clients all the time and maybe sometimes do satisfaction surveys, sometimes because they're required. Actually thinking about how to utilize and talk to the patients that are within your service to be able to understand what you should be offering, what they need, what relationships you need to build in order to link people, because everyone's going to be different. And the big thing that always happened is people like, okay, well, they're on MOUD, but they're smoking cigarettes. Well, who is it that you can talk to that's going to talk about nicotine replacement, right? And does it exist? I had this one kid who was younger, and it was in this conversation where he was using fentanyl and marijuana. He's like, I'm going to practice harm reduction. I'm going to stop my fentanyl and just use marijuana. You could have been like, don't use anything. Even if you're internally saying that, you should be like, oh my gosh, it's so awesome that you recognize that fentanyl can lead to overdose quite quickly. So let's have some conversation about the marijuana. I know this other parent that has agreed to talk to you. So that peer piece is wicked huge. But I find often we say that people aren't engaging, that they've engagement resistance because we haven't actually asked what would be useful for them. And so changing the way we think about that could be helpful, as well as some of the resources that we mentioned earlier.
Yeah, I really like what you were saying, Kima, and I totally like agree that it has to, center on the person, and in order to know how to do that, one has to engage, with the person. And it makes me think of sort of a set of larger principles that apply, I think, to both public health and clinical care, is that the work that we do is both sort of evidence-based, or at least evidence-informed, and person-centered, and that those are not in conflict with each other. Um, and that person-centered care means, ethical, grounded in human rights, and centered on the person. And sometimes people can legitimately not want, for example, medication or something like that. But that, so there can be, so when in the rare instances that the evidence, which is population health, is in conflict with the individual, which is person-centered care, we provide individualized, care. The second thing is like that there is this like really like somewhat robust, I'll just say, like ecosystem of services, there, like you mentioned some already. There's like early Head Start, there's like nurse partnerships, there's home visiting, there's early intervention, there's WIC. There's lots and lots of pieces to the system. In the postpartum period, those pieces are not really well connected to the birthing hospitalization. And in general, they're not well connected to like health systems. Yet they're, kind of critical resources. That lack of connection means, one, that providers don't really know what they are and what they do past like, maybe a superficial understanding. And more importantly, don't know how to access, those services, aside from saying, I'll fill out your little WIC form. No idea what happens over there, but you asked me to complete this. And the inverse is also true. Like like those service agencies don't really have good connections to the healthcare system. So I think there's a responsibility of the healthcare system to better connect. But there's also, I think, a real role that Medicaid can and sometimes really does play in this, in particular with the care coordination that can be provided, or case management, whatever term, like from Medicaid itself, and to really think about what the resources are and how to link them. So I think there's a lot of work one can do. Um, but in many ways, it's not a question of absent services. It's more a question of disconnected parts. So the solution is different, or the response, is different. Final thing I'll just say is that, like your examples of, people smoking cigarettes and, or like the harm reduction of I'm going to decrease my fentanyl and might mean that I increase my cannabis. Like to recognize in that people, where people are at a moment in time isn't where they're always going to be. And people's perspectives, and really confidence around behavior change varies and changes, both up and down. And so not viewing people as fixed in where they're at a particular moment, and recognizing, like the old adage that you can't step in the same river twice. That's that sort of like life course, perspective that people are like, there's stuff that's always changing. So just, sharing information for people who are not ready or interested in changing their behaviors at this moment in time, like approaching them with dignity and respect, sharing some information, that's something that they might return to at a time that you don't see them. Any questions? Since I realized thank you for the thank yous, but we are here, for the next 20 minutes, if to share and to talk, and to answer questions.
I
So
will
feel
say if
free.
there's no questions, one thing, a lot keeps me up at night. But one thing that keeps me up at night now is with the hurricanes and the storms. And I remember I was in Baltimore when Hurricane Katrina came through, and it really is thinking like, how are people going to have access to their methadone? How are they going to have access to the services that they need? And so it is unfortunately a time when there's a lot of national disasters. And it is something to think about because I assure you, that was a while ago, I realized, but at that time that was not the first population in mind, and there were not the resources necessary to ensure the continued care that people needed. And as you guys know, you're at really increased risk if you stop taking your methadone because you have no access to it, and then your body gets accustomed to not having it, and then all of a sudden you're using fentanyl or something. Like you could overdose. So not only was there not access to methadone, there wasn't access to naloxone. And I think there's a role for public health as they think of their disaster preparedness, just making sure, remember, people use substances, and pregnant and parenting people use substances in mind to ensure that continuity of care. It was a public service announcement that no one asked that question, but it did keep me up at night.
Oh, I'm gonna add to that public service announcement. Another thing that gets forgotten in sort of natural disaster response is contraception. Um, and and there is, a small literature that looks at, unintended birth rates following, different natural disasters where people were cut off, from pharmacies, to get their refills of their birth control pills or stuff like that. So I think that there's like, yeah, and yeah, as storms get worse and stronger and more severe and more common, like having appropriate planning for yeah, all those COVID babies. But like having that sort of like, yeah, built in better. And yeah. Um, and that being part of like FEMA response should be not just first aid, but also chronic disease management for people who will have lost access to their medications, either from pharmacies or losing their house or whatever. Um, but yeah, yeah. Delaware, lead the way.
And Dr. Miller said this is important as states are preparing for the next hurricane. I believe that's,
Yeah.
we were talking about Milton before the webinar. I really appreciate that point because I never thought of that either. I did also want to go back to your care coordination. I think sometimes it's really a like workflow issue, right? And I'm curious if you have any suggestions on strategies that people can use to incorporate care coordination into their work.
Yes, and what I'm about to say, I want to be like it's a conflict of interest. I want to be honest about my biases. So I worked at FQHC. You have beauty of having the care coordination baked in, right? Because of their PPP rate, they can have a case manager. And so I feel very lucky for that reality. I know that everyone's not in that situation. But if you are really utilizing, and even in that instance, helping folks understand, again, that it's a pregnant parenting person with SUD, make sure they understand what it means, and really looking for those non-punitive, non-judgmental spaces. The other space, though, if you're not an FQHC, which is similar to the PPP rate, is I really believe in team-based care. And in that team-based care, you can have any number of people who can do that care coordination. Often peers are really effective, or community health workers are really effective. And in some instances are really great because they know where the non-judgmental kind places are. There was some work that was done in LA that really took that model and then taught hospitals and other places how to be kind and non-judgmental. So it's something that could grow. But having that team-based care allows that care coordination. As I mentioned, though, there aren't enough services. We have to rethink how we do services. I'm not going to pretend, particularly in rural areas, it's much harder. But in some of those instances, thinking telephonic, if people have access to telephones and the bandwidth and all of it, and telehealth. But I'm a big believer in, and I said I have these biases, but really in this outcome-based care. And that it's aligned, right, to the TPP rate, which for those of you who don't know, FQHCs get one rate to take care of people that can include these additional services. So anyways, it's similar to an outcomes-based care rate. So you can actually pay for a care manager that patient seeks to interact with. Often we have these teens where like, that's going to be the person you talk to, and the patient may have no relationship or desire to interact with that particular person, be it the pediatrician or the front desk person. But being able to provide outcome-based care and being able to say, I have a breadth of different services and service providers at my fingertips, and I want to help create this community-based relationship, can be really helpful. But it does, I'd say, even in my work now, which is not in the clinic right now, but list of who is there. Sometimes it's just easier if you start collecting who's out there and you create this relationship, because often the providers are completely exhausted. As we're saying all this stuff, we're pretending providers have all this time with their clients, which they don't, for myriad reasons, which we won't get into here. But if you have 7.5 minutes, you need to have an easy way to do this, right? So start collecting those services that you know can be impactful and helpful, offer culturally linguistically effective services. And often you can find out, like sometimes the home visitor will help you out. Sometimes it's the WIC person who'll do some of that care coordination. Create these relationships that say, we want our folks to be well, and you'd be pleasantly surprised how many people are willing to come together.
Yeah, I love that, Kima. It was making me think a little bit about, like you were talking about workforce, and you were also talking about funding and reimbursement for said services. And not just so the FQHCs are an example of where it's baked in, which is wonderful. Another example, and this is much kind of more specific, was the arts benefit in Virginia, which was an enhanced reimbursement for addiction services, and for the OBOT, the office-based opioid treatment. There was for programs that adhered to a minimal requirement of quality metrics, they could get an enhanced reimbursement, and that included a per client per month number. I think it was, I'm going to make up the number, say $200 a month or something like that per person per month, which was set as a way that a clinic could either like use those funds for something, but also hire somebody to provide care coordination services for people with SUD. So there are ways and examples of things that can provide it. Second, sort of like the workforce, and you're right, it doesn't have to be like the named care coordinator, although it can also be, but lots of different people can perform those sorts of services. And it's, as you said before too, like one of the best ways you do that is by knowing the person. And that's the hardest part, I think, of when care coordination sits within Medicaid, because that person doesn't always know the patient, and the patient doesn't always know what their plan is, and or really have a relationship in the same way that they have a relationship with providers. So thinking about, that people like peers, patient navigators, there's all sorts of stuff or folks that work within the system that can sort of serve in to some extent in that capacity also, because again, it should not be like on the backs of the primary care health professionals exclusively. And so finally, there's also a real localness to services. And if you have the time, like, it's nice to make relationships with, like, figure out who are the home visiting programs that serve that region. Who, where, where's the local like WIC administrator sit? And just, like, just, either pick up the phone or, have, I don't know, invite people to clinic where, for lunch, and sort of names and faces and, physically meeting people really becomes the human network by which, services are ultimately like, delivered to our patients.
I think we do that a lot. I know we do that, right? You're like, the three cardiologists you like to send people to. The endocrinologists that are going to be kind to the teenager that has really brittle diabetes. And so it's something we do a lot. I do think, going back to group parenting, and there's a lot of different group parenting models. I'm not supporting one or the other, but it's also the clients themselves that have that word of mouth that you can learn from. And they're like, well, they will tell you, like, go talk to these three providers. And so you can help prioritize if you have limited time where you go and make those relationships. But I do agree with Mishka, like knowing folks. And again, it's often a win-win because at some point they're going to want to send someone to you.
I just wanted to note too that Dr. Miller wrote in the chat that thanks for including HCV as we see the numbers continue to rise in Delaware. And that keeps her up at night. And that she recently learned that RNA testing for the infant can begin at 2 months as opposed
Yeah,
to 18 months. So just things
there's
that change
yeah,
rapidly.
but yeah, that's awesome. I know it can begin earlier, but I thought you still needed a negative test at like 18 months. But maybe that's not correct.
Yes.
Um, but yeah. Oh, and I'll say it's towards the end. There has been for the last 5 years or so a clinical trial, I can't remember who funded it, looking at the initiation of medication for Hep C in pregnancy. There's nothing categorically that would lead one to think that one couldn't do that. But aside from the sort of standard, usually overstated safety concerns of medications in pregnancy, but there is a study. Nothing's been published yet. I'm waiting. I'm pretty sure it should be finished and they should be like because it was several years ago that it was started, and so that could be like a real game changer because there's this misalignment of like we have people like in prenatal care, yet when we start the medication is like when we don't. um,
Mhm.
the second thing is there are viral load changes in pregnancy that have been observed. They tend to decline. So there was historically an argument made that actually starting people like, immediately postpartum when the viral load is lower than it is earlier might be even more successful. But I think aside from that natural history, like being able to provide medications in pregnancy would be would be excellent and potentially, yeah, decreasing vertical transmission.
Can I add a third piece to this as we're talking amongst ourselves? Because the other piece that's really important is talking to communities. And the reason I say this because for Hep C, you still have people who are like, do not get Hep C treatment, right? Because they're thinking of the old interferon treatment, which was horrible, the side effects or whatever. And so a lot of it is community education. Like, no, actually, there is a different, you don't have to do the interferon. This is actually useful and cures you. But for all of this, the communities don't have the information. And there's this great group in Baltimore, CCP. I can't really remember what it stands for, but it's run by this guy, August Summers, and he works for Be More for Healthy Babies, which some of you may or may not have heard me mention before. But what they do is they go out in community with these public health messages and are like, how how do you hear these messages? What is the language that would actually be useful for you? And in this one space, they did some work around the safe sleep. And the cautionary, providers had all this language they were using to tell patients to do safe sleep. It was completely antithetical to what people actually wanted to hear. And so they're able to create communication conversations that, again, really focusing on community, really making it linguistically appropriate. To educate community, because there's righteously not a lot of trust for providers in these health systems. And so we need to go out and talk to communities in the way they can hear and build these relationships, so they're willing to engage some of the strategies that we say we're offering, because otherwise what happens is you're like, well, we offered them that, it didn't work, and then the money goes away and people are still sick. So it really has to be a joint, which is what public health is ideally in a perfect world, has to be that joint piece where we are making sure individuals, their families, the communities are receiving the information in a way that's going to be supportive and helpful and honest as well, and help them to make honest decision. If they don't want the medication, okay, but I want you to know what the medication is for, so that you're not scared of something that doesn't exist anymore, like interferon for Hep C. I would love to, yeah, I would love to chat. I'd love to share the Be More for Healthy Baby stuff, because it's really this process. And they hired this fellow, August Summer and Tina Suleiman, CCP, and I'll get you the name of that for the next oh, thank you, Laura. Center for Communication
Google.
Program.
Thanks to Google. Okay, we have about 8 more minutes. Do we have questions? Oh, I see Dr. Miller's NASTAD. I don't know if you're supposed to say that. NASTAD is doing a great deal working with states on getting things out there to communities. Ah, right. Great. I mean, if we don't have any more questions, should we give everyone 8 minutes back?
Absolutely. And you can always think of them and send them before the next one. So
Absolutely.
Totally.
Oh, thank you for that. And you remind me that I need to describe the next one for everybody. If you can just hold on 1 second. If I can successfully get there we go. So yes, November 8th at noon for our last in the 5-part series. It's the second part of the postpartum care. The link is here. It'll be in the slides when you receive them. And there's the QR code. Please share this recording and slides out, and join us for the 8th for our last in our series. And we really appreciate it. We know we've had a lot of consistent folks come and new people come. So come on, come one, come all.
thank you. Bye,
Thank you
all.
so much.
Thank you. Oh, and there's resources at the end too. Thank you, everybody.